Hawaii joins 6 other states, California, Colorado, Oregon, Washington, Montana, and Vermont, and the District of Columbia that allows terminally ill, competent adults to get a prescription to end their lives. Hawaii's law is called Our Care, Our Choice. Despite strict safeguards, it is not supported by all. Join the conversation as Insights discusses medical aid in dying. Tonight's live broadcast and live stream of Insights on PBS Hawaii start now.
Aloha and welcome to Insights on PBS Hawaii. I'm Daryl Huff. The Our Care, Our Choice Act became law in Hawaii on January 1st. Resident Hawaii adults who are mentally competent and who have a terminal illness with a prognosis of 6 months to live can request a lethal prescription to end their lives. The law has built-in safeguards and there are many steps a patient must take before a request is approved. But despite those protections, the law is not universally supported. We have with us tonight the Chief of Planning and Policy with the State Health Department, the head of a hospice organization, a terminally ill cancer patient, and a physician who supports medical aid in dying. We look forward to your participation in tonight's show. You can email, call, or tweet your questions, and you'll find a live stream of this program at pbshawaii.org and the PBS Hawaii Facebook page. Now to our guests. Lauren Kim heads the Office of Planning, Policy, and Program Development at the Hawaii State Department of Health. Brenda Ho is the CEO of Hawaii Care Choices, an organization that offers palliative care, hospice care, and bereavement care on the Big Island. She's also a registered nurse. James Wolf is a terminally ill cancer patient. He was diagnosed in May 2016 with cancer of the colon, which has since spread to additional areas of his body. He is currently undergoing immunotherapy. And Dr. Chuck Miller is an oncologist, board certified in internal medicine, medical oncology, and hematology. He has been an advocate for medical aid in dying for years. Now let me start, Jim Wolf, at your personal experience. You know, what brought you to the Capitol to come and advocate for this? What was going through your mind that you would want this option so badly?
Okay, back in 2016, when I got my initial diagnosis, it was cancer of the colon that had already spread to my liver and my lymph nodes, and so it was aggressive cancer, and the chemotherapy that I was on was very strong, very powerful. I lost about 40 pounds, and I was just basically dying. I was not able to fight the cancer. However, right when I was going to stop the chemo, I was brought up about the possibility of immunotherapy, Keytruda. And once I was on that, it stopped the growth of the cancer. And so now my tumors are still there, but the growth has stopped.
And we told you, you look great.
Yeah, no, and I feel great. I'm very, very grateful. So what brought me to the point where because I already I felt I faced death. I knew how I felt at that time. I already tried. I had 2 opinions from the physicians. I'd been on 4 chemotherapies, so I was dying. And at that time, I wanted to have medical aid in dying. I had closure with my family and my sons, and we spoke about all of that. And that's what brought me to the committee meeting the next year, that I wanted that opportunity to use that, because perhaps when Keytruda runs out, I'll be facing that same situation again.
Oh, that's quite a story. Thank you. Brenda Ho, with the hospice organization in the Big Island, you had some discomfort with this law, right? I mean, you were concerned about it.
Oh, not really. I mean, my discomfort. Understand that I'm only speaking for Hawaii Care Choices tonight, which is on the east side of the Big Island. But we want people to have choices. Where we get, and for folks feel uncomfortable, is how far are we going to lean in and be able to help facilitate folks to go through the process of getting the medications and actually ingesting the medications and so forth. So it wasn't that we're uncomfortable. I mean, the law passed, and people have the right to different options and choices. It was just really important that people are well educated. And to me, one of the things that happens with this passing of the law is the education and the awareness of what other support systems are out there. And I can tell you Hawaii has some pretty profound hospice and palliative care programs that I hope people are understanding what those are and how they wrap around families and patients and help them through all end-of-life care issues and quality of life. In addition, if they want to take this medication, it's the best place to be if you're interested in it.
You know, that's an interesting point, because I think in the debate, and it all, a lot of it is around the issue of cancer itself, right? People think, oh, I'm either going to die a horrible death or I'm going to control my own death. There's a lot more in between of all that, right?
There's so much more we can do. You know, and when you're diagnosed, and as you can share, that when you're diagnosed, your life changes immediately. And as you go through that journey, and your family goes through that journey of knowing what's next, what's the test going to show, what's the treatment, how long do I have, it's so complicated, and our system is so hard to navigate. And I can tell you, hospice is experts at navigating the healthcare system, supporting patients through that, helping them with pain and symptom management, the spiritual concepts or components of that, you know, what does life mean? Where am I going? And obviously the social, emotional pieces, not just for the patient, for the family. Sure. And that's huge.
Okay, Dr. Chuck Miller, what kind of, in advocating for this, what kind of expectation do you have of how many people might actually use it? Or I know that in one of the patients we've been following, he basically said, I just want to have it in case I need it.
It's absolutely true. Statistically is what I can give you. Out of the state of Oregon, where they've had this for 20 years, the number of deaths from medical aid and dying is about 1% of all the deaths in the state that year. So if you extrapolate that to Hawaii, it's a pretty small number.
And one thing that I was wondering about, are many of those people that might have found other ways to end their own life anyway?
Well, yeah, that's a difficult question to know for sure. There was a patient who was out in Kahala just a couple of weeks ago who shot himself. Mm-hmm. So does that happen? I'm sure it does, but my perception of why this law is important is because, as Brenda said, it allows just one more choice. And I have to say one thing, with the Department of Health's help and the advisory council, Hawaii is light years ahead of where the previous states were at this point in time. We have really well-developed step-by-step procedures and policies to ensure the patient's safety, and also to ensure that they get all their questions answered. My whole point is that every patient who requests this should be on hospice, because that's important.
Let me now move to Lauren Kim from the Health Department to talk a little bit about this. Can you just sort of go through what the protections are in the law to, prevent any kind of abuse?
The Our Care, Our Choice Act, in the preamble of the law that was enacted, describes itself as being among the most rigorous in the nation, and so that was a point that legislators were careful to make, that this is very rigorous, that there are safeguards, and that was necessary to secure the votes to pass this bill. The eligibility requirements are relatively basic, meaning you have to be a Hawaii resident 18 years or older. You have to be able to take the medication yourself. You have to be in a position to make 2 oral requests followed up by a written request, and you have to have the mental capability to make an informed decision. There are other safeguards, such as the custody of the prescription and other narcotics enforcement laws that make sure that these dangerous drugs in large quantities don't get diverted or accidentally forged or defaced, and so that when you have a person presenting with a prescription, that there are reasonable assurances for the provider, for the pharmacist, for everybody in the healthcare system and family, and even first responders, that this is a legitimate request.
You know, Jim Wolf, when you look at all the stuff in this law, how does it feel as a, I hate to call you a patient because you seem to be a vigorous guy. But,
Thank you.
For someone who's facing this possible choice, did it seem like they were putting a lot of barriers in front of you?
My feeling is that when I entered into this, there was no law. I have an attitude of gratitude that it's there, that there may be obstacles and there may be some steps that I'm not familiar with, but it gives me great comfort to know that if I ever feel as bad as I did when the chemo was getting me, and the cancer's so powerful, this would be something I would want to use, whatever those steps would be. I found that Kaiser has been very supportive so far, and I think that I would navigate it as well as all the other steps that we've gone through up to this point in time. There are, I can't speak on having gone through those steps, but I'm comfortable that I really believe that it will be improved over time, and as people become more accustomed to it, and I have faith that it will be successful, and I'm okay with that.
Brenda, in your experience with folks that are in the process of heading toward the end of their lives, one of the things that struck me about the law is the requirement that there be a prognosis of 6 months to live, which sounds very precise to me, but in Jim's case, in John Radcliffe's case, they've exceeded the prognosis. Do you think that that's something that could be a sticking point that doctors might struggle? And maybe Dr. Miller or Lauren can weigh in on this. That I'm not going to say it's 6 months. It's like
I think everybody needs to be really aware that in Hawaii and throughout the nation, identifying when that end of life is going to come is extremely difficult and challenging. And you have to look at our hospice, for example, in the Medicare benefit, is for patients that have a 6-month prognosis, very similar to the drug. Our median length of stay, meaning 50% of our patients die within 13 days of coming into our program. They wouldn't even have time to ask for the medication, and once they've been given their prognosis. So we frequently, as healthcare professionals, underestimate or overestimate, I should say, how long people have to live.
And if I may, patients like Jim and John have had wonderful opportunities, life-saving drugs and support systems. Prior to the effective date of this on January 1st, 2019, and sometime in November, I just got a cold call from someone in the public and said, my dad was given a diagnosis of 4 months to live 2 months ago, and he wants this as an option, and I'm here to make it happen for him. And I said, I will do everything I can to help you. And this was a very highly motivated, highly educated, very well-organized individual, the individual's daughter. She had read the law inside and out, and I sort of helped her, and I said, we'll be in touch, and when this when this becomes effective, I will send you the forms on January 2nd, and I will help you through the process. And so I'd sent her the forms on January 2nd, so this was about 6 weeks later. She says, my dad passed away peacefully in his home about a week later after our conversation. Wow. So it didn't come in time for some. Others, they just have that option. So it's, that timeliness, you just don't know. So I think it is a great comfort to know.
That's going to be a challenge. And Jim, when you were in the chemo and you were so miserable, and if you would have had the medication, it might have been tempting to take it. And technically, once you had the other medication offered to you, and that changed the course of your dying to be where you're sitting here with us looking totally awesome, by the way, that you didn't, if you would have taken it then, you might have missed something. So I think this is an option for people. But and
actually, if I could interrupt on that point, you described exactly that when we were talking earlier. The
thing is that I had gotten to talk to two physicians, and even had a video conferencing with MD Anderson. So I was pursuing all options that were on the table, and the Keytruda was not an option. It wasn't even approved at that time. So you're right in saying that it might have gone that route, but it's kind of like a what if. If I was presented with that without any guarantees it would really work, and I chose it simply because I wanted to live. So I would always choose whatever options are available to live. And if there were no options available, then I think it is the time when you have exhausted all your options and it's time to ask for medical aid in dying.
But during this period, I'll be right back with you because I know you have a lot to say on this, but you also had an additional got to know a new grandchild during this period of time.
Absolutely. I mean, what made me cry, I mean, you never know what you're going to face when you actually accept death. And I cried about not being able to spend time with my grandchildren. And now I have two. And clearly that has given me the strength and the pleasure of that. So yes, that to me even makes me emotional right now. But that's that opportunity for 2 years with them is priceless to me.
You're totally entitled.
Yes.
I just to go back to the issue of the 6 months.
Yeah.
You know, for both John Radcliffe and for James, if they choose to stop treatment, they would be dead in less than 6 months, without a doubt. So.
Oh, I see. So it's almost like a combination of factors that are like.
Yeah.
I see. I understand. Go ahead and describe what you're describing.
Well, it is, and it's, you know, the drugs that we're coming up with, the pharma is coming up with, are just amazing with their responses to treatment of cancers. But it doesn't. It doesn't always. It isn't always enough for the patient. And I can tell you, I've seen so far this month, I've seen 7 patients who have requested medical aid in dying. And none of them, they've initiated the process, but none of them are any place approaching the 20-day period where they would be eligible, or I could write them a prescription.
Describe that part of the process for me. What's the 20 days?
Okay. The patient has to come to me and make an oral request that they would
and then
like
20 days later,
medical aid in dying. Then they have to also do a written request, and that has to be after they've been seen by 2 other providers, by the consulting physician and the mental health provider. And they can do the written request, and then their timeline is 20 days after that first oral request, they have to do a second oral request. So I know this was all put in there for safeguards, but I can tell you 2 of the patients that I saw in initial consultation are dead. So it needs, the law I feel needs to be tweaked a little bit, because I think this is the longest of any state.
Correct.
All the other states require a 14-day waiting period.
You know, and also it would strike me that if someone is in a degree of discomfort and pain that they've made that first request, 20 days is going to feel like 20 years.
And that's,
Unless they're with hospice.
Okay.
and that's that 20, the law has built in, hard-coded 21 or about 22 days of waiting periods. That's if you can get all the appointments exactly when you want in a row. And how often have you been able to call up a doctor and say, can I see you Tuesday at 3? So we do encourage health systems to prioritize these patients. We're very fortunate that Kaiser as a closed system has stepped up with their considerable resources and navigators to help patients move through this process. But our number one piece of advice, as Brenda mentioned, is concurrently enroll in hospice.
Yeah. You know,
And educate physicians, because in those, we've got to be able to better identify individuals and what their life expectancy is.
You know, questions are starting to come in from our viewers, and we really appreciate that. On this point, on the point of access to care and this timeline, how can those on the neighbor islands effectively access this law given existing social and geographic obstacles to obtaining other forms of medical care? I mean, you're on the Big Island. How much of a challenge do you think that's going to be unless they're in hospice, as you're saying?
Well, and by the way, there's 3 hospices on the Big Island, and we cover the whole island. So we definitely encourage anyone that has a life-threatening disease or terminal disease to call us immediately and get engaged. And we help people navigate the healthcare system. So if people aren't interested or are unwilling to reach out to the hospice organizations, I think this law is all about the primary care physician, your physician, and you as a personal choice. And so if you don't have a primary care physician, call your insurance company and tell them that you really need someone, and just try to connect.
I just want to throw out one comment from a viewer. Said Stephen Hawking received his 6-month prognosis when he was in his 20s. He lived 50 years after. But Lauren Kemp with the health department, so when we talk about this strict timeline, how would it be enforced? I mean, if a doctor had this patient in front of them and they thought, you know, this is ridiculous, I want him to have this now, and then assisted with that, what would be the ramifications of that?
It's an interesting law. It identifies the Department of Health as the implementing agency, but it's important to point out that we were not given rule-making authority or legal enforcement authority. It is at its heart an immunity bill, particularly for physicians providers who follow all the steps and make a good faith effort and can demonstrate and document that. So that's why there are a lot of forms. Everything is documented, and that's what's going to protect the physician.
Just to clarify, immunity bill, meaning you follow this, you can't be sued by somebody, right?
Manslaughter, negligent homicide.
Oh, or charged criminally.
Criminally. If you're acting in good faith and you have documented everything to the hilt and followed the procedures, the letter of the law is that you shall be immune from prosecution.
Yeah.
Let me just go back to the issue about the outer islands. I can't speak for the other health systems, but I'm seeing a patient in Kona on Monday. Last week I saw a patient in Maui. So Kaiser is adapting and providing that service on all the islands where they have clinics.
Okay, so that opens the question of how is the rest of the healthcare field doing? I mean, you're hearing from a lot of doctors and facilities like,
those conversations are happening. So we had spent about 6 or 8 months under the guidance of our advisory group to figure out what kind of information physicians, everyone in the healthcare system, what they need to be supportive of this or decide to what extent they would like to be engaged with medical aid in dying. You know, there are obviously going to be some hard no's, particularly religiously affiliated organizations. And there were some very supportive folks, and most folks are going to be in between. This is new, this is change. We've had a lot of discussions with the health plans, talked about coverage and costs, with provider groups, with health systems. We are very pleased to see that many of the large health systems have a version of a policy called engaged neutrality, which means they do not come out and support or oppose this. They may place some restrictions on, you know, for example, you can't do this in their inpatient facility, but their physicians in their outpatient network or in the office buildings are free to have these discussions and support their patients' decisions. So we're very pleased about that. We are concerned about access on the neighbor islands. If you're living in Honolulu and you're a Kaiser patient and you can get yourself to Moanalua, they have wonderful navigators. We met with them and you're in good hands. I am concerned about the solo practitioner in Naalehu or the individual in rural Kauai.
Kau, yeah.
Yeah, Kau.
Yeah. This is a question that is along these lines. Will there be physicians who can opt out due to their own ethical beliefs? If so, what if a terminal patient does not have access to a participating doctor? And anybody can go for this.
I think that's. I think that over time will not be an issue. This, as Lauren said, this is new for almost every healthcare provider in the state, and I can tell you, for the oncologists that I used to work with in Kaiser, you know, before this thing became law, they didn't have the time to read about it and learn about it. So the most important thing that the next 6 months or so is to educate providers and educate family and patients. And just to go back to how important the hospice is, Oregon has one of the highest rates of hospice engagement in the country. It's like 90%. It's huge. We have, I don't know, 12%, 14% here in Hawaii.
Engagement meaning end of life?
Yeah.
People?
Yeah, that patients that enter hospice at the end of life. And what they found, all the states where these laws have been enacted, the hospice use just skyrockets. And that in and of itself is a terribly important thing for end-of-life care.
I just to answer that just a little bit, I think Oregon, there was a high utilization of hospice and palliative care prior to the law going into effect. And so it continued afterwards.
Well, it's been 20 years in Oregon, right?
Yeah, so there's no, I haven't seen any data, and Dr. Miller, excuse me, you might have, that showed that there was because the law was passed, there was an increased utilization. But I can tell you here in Hawaii, and I agree with Dr. Miller, just because of the conversation and people watching tonight, being aware of what options are and the comprehensive, all-inclusive Cadillac service that you get under the hospice benefit is not anywhere else. And so, and we're underutilizing that in the state of Hawaii. So I do hope that with having these conversations, that we're able to really penetrate and encourage people to seek our help, because that's why we're here.
Is there enough hospice beds in this state to, if you actually did have?
Thank you so much for asking that. Hospice is not about a bed. So hospice is about going to where you live, providing and circling you with nurses and doctors and social workers and spiritual counselors and volunteers and
So
a
it's
whole
not limited
array of,
in that
and it
sense.
really is meant to be home, because we want to empower you to be able to stay in your own home environment around your loved ones. So we don't not just take care of the patient, we really embrace the family and help them through this journey as well. So we walk right beside them. So I think it's really important. While we have an inpatient facility, because we really wanted our community not to have to leave the islands if they're too sick to be in their own homes, so we built the First Neighbor Island 12-bed inpatient facility, but not everyone has that and or needs that in order to have quality hospice care.
Okay.
Jumping very quickly back to Neighbor Island Access.
Sure.
Telehealth is specifically identified as a means of shrinking the distance between patient and provider.
This is like a Skype doctor.
We would prefer a little more secure applications, but the law says, particularly specifically for the medical evaluation, that a telehealth visit is allowed, and telehealth is another underutilized service. We have very progressive, permissive telehealth laws, and we're not doing enough of that either. So that is an option that we're going to continue to push.
Let me go to another viewer question, which is on the point of, you mentioned that, this law can help a doctor facilitate this process and not be sued or prosecuted. I'm getting a couple of questions about people who are a little afraid that they might be forced to help a patient do this, even if they don't want to. I think this is a question. I think every hospice or nursing home should make it clear before anyone can sign up whether the home will allow a patient to use the new law. Many are owned by religious groups who regard suicide as a mortal sin and refuse to allow patients to take a death pill in the home. I'm not sure who would be able to answer that question, but how much of a problem is that?
It starts with the law. The law, the letter of the law says that if you choose to participate, you cannot be sanctioned professionally, civilly, criminally, as long as you're following the procedure. It also says that if you decide to opt out, that cannot be held against you. And we've been pleased with discussions we've had with community partners that policies and procedures are in place. For example, if an individual pharmacist decides at the window, I cannot fill this for you, We understand, at least on the mainland, some large chains will say, okay, let me get a different pharmacist to do that. And if that person has a philosophical objection to it, it is the obligation of maybe the store manager to find a different location to refer that patient to. So, we are drawing from the experience of other states who have lived with this a little longer.
But the bottom line of what you're saying is that it doesn't force any healthcare provider to do anything.
They may participate, they may not participate, and in either case, there shall not be sanctions.
Jim, I'm wondering whether a little sort of network has developed among folks like you who were involved in the, sort of supporting the law. Do you talk to other patients about what they're going through? Is there much connection, or
I'm speaking for myself. I don't think I'm in any. I did attend some support groups back when I was on the chemo, but since then, I find that my support group is the oncology nurses and the doctors and the physician's assistants. Kaiser is, in terms of, other than my family, Kaiser is my support group. And I think, to me, when every 3 weeks I have an infusion, and I just feel that they treat me with respect, and they talk about, the illness and how I feel. And I think that is a support group for me. It is actually the oncology unit and certainly the doctors that I meet with regularly, or the physician assistant. It means the world to me because they know where I'm at and they are checking on me, and that's what I have.
Let me, quite a bit more questions are coming in, and they're getting very specific now about how this is going to work. One question is, if a patient has enough pain management that they are not in pain at the time of death, why do they need the medication choice option? Doctor?
It's very clear. We know from the research that's been done, the issue of pain control is way down on the list of why patients choose to have medical aid in dying. The biggest one is loss of autonomy, loss of independence, loss of quality of life.
Unable to enjoy things
Yeah,
that they used to.
That's the thing that people want to control. Most of the time, hospice can take care of pain, and they do it very well, and palliative care and the whole bit. But it's the patient's choice and their brain that says, I want to be the one to decide this. I want to decide when, where, how, and with whom I'm going to die.
That was a very strong sentiment as we had community meetings, and just members of the public were shocked that they couldn't do this already. It's like, why can't I walk into my doctor and do this? It seemed like a natural right to them. On the flip side of that, our advisory group, their number one piece of guidance to us is to emphasize that word choice. This is not, the department implemented this not as a rush to the lethal prescription. This is the legal standard. One of the legal standards for implementing this law is that the provider must educate the patient on all available options. In Oregon's experience, there's a good number of people who never take the pills. They may expire, they may live a long time, they may expire from the disease and choose to go naturally, or they may expire for another reason. But
do you know what the number is associated with that?
It's about a third, I think. Is that correct,
Yeah,
Dr. Miller? Who go through the process but never ingest the medication. And so it's those options that are very important, and the options and the education that we need to take the conversation upstream. It's about advanced directive. It's about provider orders for life-sustaining treatment. It's about understanding palliative care. It's not being fearful that hospice care is death care, because it is not. That's the strategic opportunity for our state.
It's one, to go back to Lauren's, the Oregon experience is about a third of patients who get medication never take it. So, and I would anticipate we would have a similar percentage here. My goal, or one of the things that I want to try and do this year, is to get the message out to patients and their families that, even if you don't have a terminal disease, even if you're not going to die in 6 months, talk to your physician about end-of-life options. How are they going to deal with that?
Jim, when you were diagnosed, What condition were you in emotionally to have that kind of a conversation? I mean,
I was in shock.
Yeah.
I mean, I didn't see that coming at all. And yeah, it was total shock. I called my two sons, and I was just like, and I was told initially that it's quite serious, you know, and actually, I had that diagnosis when I was getting a physical on a diving trip, actually, and the doctor looked me up and down. He said, "Well, you look pretty fit. 6 months." I mean, that was just. But they didn't.
Wait. Seriously?
Yeah, seriously.
He said, "You've got this cancer. You look pretty good. I give you 6 months."
Yeah, this was in Bangkok. I went to an international hospital because I was on a diving trip, and
diving like scuba diving.
Yeah, and snorkeling.
Okay,
And
so you
I got
were
a physical
fit
there.
guy.
Yeah. I mean, I'd actually had that physical a year earlier for a different trip. And they did the same abdominal ultrasound, and I didn't have anything. And now, a year later, so that's how, when I came back with Kaiser, they knew it was an aggressive cancer, because in 1 year it had already spread all over. And so I was just total shock. And then I just wanted to start treatment, even though it looked kind of dismal, but I talked with my sons, and they said, you try everything, you know. So I was open to everything, but I mean, when you're told that, it's pretty shocking.
It's pretty shocking, but there's a reluctance to tell on the provider side. They don't want to have that conversation, or they're resisting at some point. It's funner, or it's not funner, but that word comes from. But it feels better to tell somebody, well, maybe if we do this chemo, or maybe if we have, if you do some rehab, or
We got this trial.
well, we've got this trial. But what happens with that when we're not, at least, so I almost admire the fact that they just said you have 6 months, because what that does for you is that's a very painful message to hear. But from that point on, you knew what you were dealing with, versus still focusing on the cure, still focusing on that I can do this and I can do that, and all of a sudden it just throws you off, and you're actively dying, and you're like, wait, I've not had the conversations I want to have. And so I just really, I almost wish that we could get more comfortable with telling the truth of what this disease is earlier in the process. So if they want this option of taking a medicine, or if they want, we're able to help them process through that. And by the way, if they get better, they can always go out of hospice. So it's because we're all about living, and we're all about that quality of life. So I just want to say that.
I need to go through, we've got a lot of very nuts and bolts kind of questions coming in, and I think that was sort of the intention of this show, is that the law is now the law, and there are questions, there are moral questions that people have brought up, religious questions, but what we're trying to focus on today is the nuts and bolts of how this works, and the challenges ahead for making it work. So a caller says, how much do doctors make helping patients with assisted suicide, which is a big, thing that gets thrown out there, that, maybe this is a way of saving money, or making money in this case. What about the Atlantic article that says these drugs cost $35,000 per year?
Wrong.
Doctor? Okay, all right. But I mean, back to the question, what is the financial implications of going through this process for a patient or his family?
Again, I have never practiced in an independent fee-for-service. I have been in socialized medicine for 30 years in the Army and 9 years in Kaiser. So in that system, you don't make
it's a $1 copay. Yeah.
It's a whatever it is. That's exactly right. But the drugs, and we can talk about this a little more, the drug that used to be the number one drug was secobarbital, which is an old time, it's been around since the 50s, sleeping pill. And the company that bought the rights to produce it jacked the price up, but $4,000, not $35,000. So that's what
That's the open market price.
That's what Kaiser would have to pay if they were able to get it, and that's another story in itself. It's expensive. There is another option that. But
let me just throw this out, because I think that some of the critics of this concept say, oh, well, the medical field some people in the medical field like this because, you know, it's cheaper to get rid of a patient than it is to treat them. But if it's thousands of dollars to go through the process of assisted suicide, that's not necessarily saving anybody money.
And I with all due respect, I have to say that I've been a physician for 40 years plus, and I certainly know, I don't know of any oncologist or internist who would ever think that way. It doesn't happen.
Okay, are you hearing this kind of concern now? And how does the law deal with this? And what is the drug, and how much does it cost?
Well, in terms of your first question about, or the concern about who's making money off of this, if I can be glib, we're talking very small numbers. Oregon has a population of about 5 million people, and they get a couple of hundred people who petition this process every year, make it through. Less than a third annually ingest the medication. Hawaii has about 1.4, 1.5 million, so we're talking maybe in a busy year a few dozen of patients who would avail themselves of this right to request. And so in the grand scheme of things, a couple of office visits and one drug that is unfortunately expensive because of market forces, the health system's not really, no one's going to be making money off.
Let me ask,
the numbers are too small.
While we're on this subject, you know, what I've heard before, and I bounced this off you folks earlier, there's talk of 100 pills, and people aren't sure what that means. Can you describe what the actual product looks like, how it works, if someone chooses to do this?
Maybe Dr. Miller,
It's yeah, it's like there is a what? It's Compassion Choices has a video that this patient in California allowed them to film him on the last several days of his life, including when he was taking the medication. So what the medication, the Secanol medication is 99 or 100 capsules. You have to break the capsules open. You have to dump the contents in a glass, all of them. You have to mix it up with some liquid, which can vary. And then you have to actually consume the medication as fast as you can. Let me put it this way. The quicker you drink all of the medication, the quicker you'll fall asleep. Mm-hmm. And I've talked to patients about this. I've said, you know, everything in this law is completely reversible. You can change your mind anytime, day or night, ever. The one thing that is not reversible is after you take that medication, because you will die. So that's the nuts and bolts of it, and that's what that's the kind of a conversation that the attending physician has to have with these patients, and talk to them not just about the medical aid in dying, but also about palliative care, about hospice. There's a thing called terminal sedation, which patients can avail themselves of. There's a thing called voluntarily stop eating and drinking, mm-hmm. which is something I would not recommend, but people do that.
So
I want to answer
sure.
part of that question. I'm so sorry to interrupt you.
It's fine.
But I do think that the law and our physicians are really maxed out, especially on the neighbor islands. So the disadvantage of the law, it causes an additional burden to the physician on the paperwork. And this isn't a conversation you have in a 10-minute office visit. We're looking at 30 minutes to an hour, multiple times, and it truly is a burden. And then the paperwork the physician has to submit to the Department of Health, and so I don't think we should underestimate what we've required required now of our physicians in their practice, where they cannot get paid and challenged. By the way, Medicare patients can't, if you only have Medicare insurance, Medicaid right now, I know we're trying to work on that, but there's a lot of insurances, but primarily Medicare, that doesn't pay for this, and you can't access it. So if you don't have additional
you
means,
access it if you
additional
had the money.
means, right.
I can
So
see
I just want
I was
to,
picturing a GoFundMe page. I don't.
well, possibly.
Could be. Caller has Alzheimer's. I'm so sorry for what you're going through. How would she take advantage of the law before she is unable to make an informed decision?
Right now, she can't.
Yep, this scenario came up in our advisory group as we sort of looked at all the different ways we can break the law, or not break the law, but you know.
Hey, wait, that was the wrong, I wasn't in that advisory group, Councilman.
Find situations that wouldn't fit the parameters of the law, but where patients had an equally dire or desperate need.
Yes.
And there is a mental capacity evaluation that needs to be performed by a licensed clinical social worker, licensed psychologist, or psychiatrist that gets to their ability to make a competent and informed decision. And you know, that could vary from day to day. I mean, I'm sure, Jim, you weren't dancing cartwheels when you got your diagnosis. You must have had a very heavy emotional response and potentially depression. But that doesn't mean that you still can't make a very good, logical, informed decision, and you know all the options. Dementia is a very serious illness where some of those competencies are called into question.
And it's at the time of asking for the medication and the time of ingestion, because you have to be able to ingest it yourself. I mean, you have to be able to take it. People cannot assist you in, they can hold the cup up there, but you have to suck the straw.
And the other part of that is, you, in no state that I'm aware of, can a patient who has, let's say, who has very early Alzheimer's, just a touch of dementia, but is otherwise, you know,
Functioning.
and very well, high functioning, they can do advanced directives and say that when they reach a certain level that they would like to have medical aid in dying. But as far as I know, no state has in their laws a way to provide that. So it's not, in other words, it's the family comes to me and says, well, she had this medical, advanced directive, and when she said, I can't get out of bed by myself and I don't recognize my grandchildren, I want to have medical aid in dying. Can't do it.
You know, this question kind of keeps coming up in different ways of asking the same question. Why do we not have the availability to have medically assisted death regardless of our medical condition?
Well, that's a,
you know,
Switzerland, the Netherlands, Belgium have pretty open euthanasia laws. I think we're a long way from that yet.
Just so I understand, what does that mean? What does euthanasia mean in those contexts?
It means that the patient can request for, I don't even remember all
But
that.
it still has to be the patient making the request.
The patient has to make the request, yes. And that usually involves the physician injecting first the drug to put them to sleep, and then second the drug that will stop their heart.
Okay, another nuts and bolts question. Does a patient need to disclose this option to their insurance company if they buy life insurance?
The requirement to disclose, this is a very private medical matter, so this is covered by federal privacy laws that have very stiff penalties for breaches. That being said, the law has specific provisions that if you are a medical aid in dying, if you expire because of medical aid in dying, that it cannot affect life insurance, probate, or similar estate issues where a determination of suicide as a cause of death would disrupt those benefits.
Okay, say that again. So what you're saying is, if you've gone out and bought a $200,000 life insurance policy and you use this, even if the life insurance policy says we're not going to pay you if you commit suicide within a certain amount of time, you still get the money?
I can't comment on the sequence of that event,
Okay,
but
all
the
right.
legal standard is that the death certificate shall list the underlying terminal illness, so cancer or ALS, not suicide. And the law, other parts of the law say this shall not be considered suicide for purposes of life insurance, probate, et cetera, et cetera.
I think that's the important point that Lauren brings up. Their medical ethics some go back and forth with this, but most people feel patients who request this are not committing suicide. Okay, suicide is someone who doesn't want to live; they want to die. Our patients, they want to live, but they don't have that choice because it was taken from them by their disease. So they want to live, but if they can't live, they want to have control, and that's what the law is about.
In your experience, Brenda Ho, with patients, do you think that that's really a thing, that someone would commit suicide after buying life insurance and abuse the law in that way?
No. I mean, nobody wants a terminal disease or to die. I mean, I think we're so far away from that. I'm sure there might be people out there that would do that. I mean, I don't want to be that naive.
But there's also pre-existing conditions, right? By the time you're at this stage, you will have had disease most likely, and you probably wouldn't have been able to buy that life insurance.
I mean, first question is, have you recently been diagnosed with cancer? I mean, that's the life insurance first question. Mm-hmm. And if you lie about that, then that would disqualify you, not the fact that you took the medication. So
okay.
I don't see that that's a big threat, but I do think there's a lot of safety in the way the law was written, that your life insurance and wouldn't be jeopardized by this act.
You know, that, Jim, that privacy that is promised in that, does that make a difference to you? I mean, that if you indeed use this at some point, that it wouldn't be what they put on your death certificate?
I think my understanding is what was said here is that I have cancer, metastatic to a bunch of other organs, and it would be important to me that they wouldn't put suicide on my death certificate, just for the sake of my family, and you know, how did Pa die, you know, and he had cancer. So yeah, that would be very important to me, in addition to the legal aspects, but just the description to me would be painful if that occurred that way.
Let me jump in. We talk about nuts and bolts, because there was at least to be a surprising path that we walked down as we implemented this. We had expected to talk to the healthcare system, but we spent a lot of time talking to first responders and law enforcement, and the importance of this being classified as an attended death, meaning it was planned, there was physician, healthcare provider involvement. We spent a great deal of time speaking with the chiefs of police on all the islands and EMS to make sure that paperwork is in order. You know, the last thing, I characterize it as, we don't want to see yellow tape around a house. There's enough grieving and suffering. And that's again why hospice is our number one, concurrent enrollment in hospice is our number one nuts and bolts piece of guidance to families.
You know,
there's the care part of it.
Yeah.
There's also at some point you're going to have again, graphic description, a body in your house. Who do you call? Do not call 911. Do not call the police.
In fact, yeah, just on that point, I was at a police commission meeting what day is today? Thursday, yesterday, where the police chief said, oh, we're now in the process of trying to train our officers to find out when they're dealing with a person who has taken this drug and passed away. That's not a unattended death. That's not a suicide. It's, you know, it is, as you guys are describing, it's just the end of a process. That can get complicated.
Very, especially on the neighbor islands, because that's what, even in the hospice, that becomes complicated, depending on the training of the police officer that's called. And each neighbor island does it a little bit differently. So again, I guess the law is brought it to the attention of the discrepancies between how it's done here in Oahu compared to the neighbor
And
island.
that was very important to have that neighbor island perspective, because at least me and a few others in my office were surprised to learn that the coroner on the neighbor island is the chief of police. It's not a standalone agency like the medical examiner. And I'm very grateful to hear that our contacts in HPD, Assistant Chief Mann and Lieutenant Tamis, sort of carry that conversation forward to the police commissions.
We only have about a minute left.
Oh,
Fastest hour in television. You know, I got two questions about potential, like sort of a spreading effect. If 1/3 of patients don't take the prescription, what happens to it? How do doctors make sure it doesn't end up in the wrong hands? Will this influence youth to take their lives if they realize the state has sanctioned self-termination? In other words, you know, is this, and this is the last question I'm going to ask tonight, is this something that will open the door to more people committing suicide?
No. It hasn't happened in other states where this has been approved. And the medication thing, okay, with hospice right now, it has nothing to do with the medical aid in dying, but hospice patients will have sometimes large amounts of heavy-duty painkillers, opioids, et cetera, et cetera, et cetera. The patient passes away, and the family usually will call hospice, and they
we're
can
usually
turn them
there.
in. Yeah.
And what about the whole message that suicide is okay?
It's not suicide.
Yeah, not in these cases, I see. That's a good
I
point.
just think that we just really need to make sure we're communicating. I think we need to get the message. This is for a very, very small, defined population of even terminally ill people. And I don't know that it will get crossed over to children.
Great. Thanks so much. Thank you guys very much. Mahalo to all of you for joining us tonight, our viewers, and we thank our guests, Lauren Kim, Chief of the Planning for the State Health Department, James Wolf, terminally ill cancer patient who was brave enough. Thank you so much for sharing your story today. Brenda Ho, CEO of Hawaii Care Choices, and oncologist Dr. Chuck Miller. Next week on Insights, legalizing recreational marijuana. Several states have already done it. Should Hawaii be next? I'm Daryl Huff for Insights on PBS Hawaii. Ahui ho.